Hypothyroidism is a common condition with various causes, but autoimmune disease, Hashimoto's thyroiditis, and thyroid failure following surgical treatment of thyrotoxicosis account for over 90% of cases, except in areas where iodine deficiency is endemic. Women are affected approximately 6 times more frequently than men. The clinical presentation depends on the duration and severity of the hypothyroidism. Those in whom complete thyroid failure has developed insidiously over months or years may present with many of the clinical features. A consequence of prolonged hypothyroidism is the infiltration of many body tissues by the mucopolysaccharides, hyaluronic acid and chondroitin sulfate, resulting in a low-pitched voice, poor hearing, slurred speech due to a large tongue, and compression of the median nerve at the wrist, carpal tunnel syndrome. Infiltration of the dermis gives rise to non-pitting edema, myxedema, which is most marked in the skin of the hands, feet and eyelids. The resultant periorbital puffiness is often striking and may be combined with facial pallor due to vasoconstriction and anemia, or a lemon-yellow tint to the skin caused by carotenemia, along with purplish lips and malar flush. Most cases of hypothyroidism are not clinically obvious, however, and a high index of suspicion needs to be maintained so that the diagnosis is not overlooked in individuals complaining of nonspecific symptoms such as tiredness, weight gain, depression, or carpal tunnel syndrome. Care must be taken to identify patients with transient hypothyroidism, in whom lifelong levothyroxine therapy is inappropriate. This is often observed during the first 6 months after subtotal thyroidectomy or iodine treatment of Graves' disease. In the post-thyrotoxic phase of subacute thyroiditis and in postpartum thyroiditis. In these conditions, levothyroxine treatment is not always necessary, as the patient may be asymptomatic during the short period of thyroid failure. Investigations. In the vast majority of cases, hypothyroidism results from an intrinsic disorder of the thyroid gland, primary hypothyroidism. In this situation, serum T4 is low and TSH is elevated, usually in excess of 20 μl. Measurements of serum T3 are unhelpful since they do not discriminate reliably between euthyroidism and hypothyroidism. Secondary hypothyroidism is rare and is caused by failure of TSH secretion in an individual with hypothalamic or anterior pituitary disease. In severe, prolonged hypothyroidism, the electrocardiogram classically demonstrates sinus bradycardia with low voltage complexes and Saint segment and T-wave abnormalities. Measurement of thyroid peroxidase antibodies is helpful, but further investigations are rarely required. Management. Treatment is with levothyroxine replacement. It is customary to start with a low dose of 50 micrograms per day for 3 weeks, increasing thereafter to 100 micrograms per day for a further 3 weeks, and finally to a maintenance dose of 100 to 150 micrograms per day. In younger patients, it is safe to initiate levothyroxine at a higher dose, for example, 100 micrograms per day, to allow a more rapid normalization of thyroid hormone levels. Levothyroxine has a half-life of 7 days, so it should always be taken as a single daily dose, and at least 6 weeks should pass before repeating thyroid function tests and adjusting the dose. Usually by 25 micrograms per day. Patients feel better within 2 to 3 weeks. Reduction in weight and periorbital puffiness occurs quickly, but the restoration of skin and hair texture and resolution of any effusions may take 3 to 6 months. Most patients do not require specialist review but will require lifelong levothyroxine therapy. The dose of levothyroxine should be adjusted to maintain serum TSH within the reference range. To achieve this, Serum T4 often needs to be in the upper part of the reference range or even slightly raised, because the T3 required for receptor activation is derived exclusively from conversion of T4 within the target tissues, without the usual contribution from thyroid secretion. Some physicians advocate combined replacement with T4 and T3 or preparations of animal thyroid extract, but this approach remains controversial and is not supported by robust evidence. Some patients remain symptomatic despite normalization of TSH and may wish to take extra levothyroxine, which suppresses TSH. However, suppressed TSH is a risk factor for osteoporosis and atrial fibrillation, so this approach cannot be